Good afternoon. Thank you to Roche Vietnam for inviting me to speak about the Ventana HER2 dual-ish assay, and I'll share how this assay can make HER2 confirmation be a bit more convenient. My name is Dr. RICHIE LAZARO. I am the regional pathologist in the non-commercial division of Roche Diagnostics Asia Pacific, based in Singapore. I'll cover the HER2 background, the value of Ventana HER2 dual-ish assay, its interpretation, and a little bit about HER2 dual-ish image analysis algorithm as it is used in digital pathology. Now, breast cancer comprises 24% of all female cancers and is estimated to claim the lives of more than 600,000 globally each year. 15 to 20% of breast cancers overexpress HER2 and are eligible for HER2 targeted therapies, which are proven to improve outcomes. Gastric cancer has the third highest mortality rate, with more than 750,000 deaths per year. There is growing evidence that HER2 is an important biomarker and a key driver of tumorigenesis in gastric cancer, with studies showing amplification or overexpression in 7 to 34% of tumors. Demonstration of HER2 gene amplification and or protein overexpression is essential for selecting patients for trastuzumab therapy. How do we test for HER2? It depends on the HER2 gene alteration for evaluation. Most commonly, we test for HER2 gene copy number alterations, such as amplification or polysomy, or less commonly, HER2 gene mutations, which lead to HER2 RNA overexpression and HER2 protein overexpression and post-translational modifications such as phosphorylation. In clinical practice, we evaluate mainly protein expression using immunohistochemistry and gene amplification status using either fluorescence in situ hybridization, which requires a fluorescent microscope and a dark room, or silver-ish or chromogen-ish or dual-ish, which may be viewed in a conventional microscope. Dual probe-ish assays are recommended by guidelines, and these are demonstrated by the red and green signals in fish and the black and red signals for dish, representing HER2 and chromosome 17 gene copies, respectively. As per HER2 guidelines, if the HER2 IHC is 2+ equivocal, a reflex confirmation with ISH is to be performed. Looking at the 2018 HER2 guideline by the American Society of Clinical Oncology and College of American Pathologists, we report IHC as 3+ if membrane staining is complete and intense in more than 10% of tumor cells, and 2+ if complete membrane staining is seen but is weak to moderate in intensity in more than 10% of tumor cells. And for these, we reflex to ISH, and if the result is either a 2+-ish amplified case or a 3+ IHC, the patient is eligible for HER2 targeted therapy. Until last August 2022, 0 and 1+ were considered HER2 negative, for which there was no targeted therapy available. 3 months ago, you might have heard of the recent FDA approval of the first targeted therapy for HER2 low breast cancer. HER2 categories are going beyond the binary results of positive versus negative and is including HER2 low, which is defined as IHC 1 plus or IHC 2 plus with a negative ISH test. HER2 low comprises 55% of breast cases, whereas HER2 negative, which is IHC 0, comprises 30%, and HER2 positive breast cancer comprises 15%, with a HER2 positive defined as 3 plus IHC or a 2 plus with a positive ISH test. Although HER2 low is a new category that is still evolving, we now know that HER2 in breast cancer is expanding in the spectrum of categories that pathologists need to evaluate accurately. If an IHC result is 2 plus, the need to reflexly test for ISH remains. With new therapies now available for HER2 low, which is either 1 plus or 2 plus ISH negative, in addition to the HER2 targeted therapies that we know for HER2 3 plus and HER2 ISH amplified cases, the need for an accurate ISH test is becoming more critical. Let's talk about the value of the Ventana HER2 dual ISH assay. Unlike FISH, which requires a fluorescent microscope viewed in a dark room, the Ventana HER2 dual ISH stained slide is viewed using a conventional microscope or using digital pathology. The dual ISH slide may be viewed in conjunction with a HER2 IHC slide and provides the morphological context of the tumor. The slide may be visualized at lower magnification for the pathologist to identify the invasive carcinoma and internal controls. Tumor heterogeneity is more readily observed in comparison to a FISH slide, and it avoids the need for oil immersion lens. Unlike FISH signals, dual ISH signals do not fade over time, allowing other pathologists to review difficult cases, and the slides can be stored long-term. The current Ventana HER2 dual ISH assay is an improvement of the previous Inform HER2 DISH assay. The silver chromogen labels the antibody linker that binds to the HER2 DNP labeled oligoprobe, whereas the naphthol fast red chromogen labels the antibody linker that binds with chromosome 17. Here is an example of a HER2 3 plus IHC slide and its corresponding HER2 dual ISH slide to demonstrate what amplified HER2 may often look like, with clusters of black HER2 signals and at least 2 red signals of the chromosome 17 within the same cell. Notice that H&E, IHC, and ISH are all viewable within the same tumor area, as they can all be viewed in a conventional microscope or with the use of digital pathology. Here is an example of HER2 IHC 0 as an example of a negative case with its corresponding non-amplified HER2 dual ISH slide, where there are 1 to 2 black signals and 1 to 2 red signals per cell. Again, HER2 clusters are present in this amplified case, and the copy numbers are estimated by the reader. 1 to 2 chromosome 17 red-ish signals are present per cell, and these are viewable at 60x magnification. In this example of a non-amplified case, there are more than 2 silver or blackish signals and reddish signals in the tumor cells, easy to score at 40x or 60x magnification. The Ventana HER2 dual-ish has been compared with FISH in breast cancer through a multi-site method comparison study using Abbott Vice's PathVision HER2 FISH kit as a comparator device. Approximately 600 individual breast cancer cases were stained in 3 central labs. Positive percent agreement was 89.4%, negative percent agreement was 96%, and overall percentage agreement was 92.7%. Cases that were discrepant for amplification status were presented to a panel of 3 pathologists who were otherwise not involved in the study. The panel reviewed slides stained with H&E, 4B5 IHC, and the Ventana dual-ish and FISH images for each of the 44 discrepant cases, which were not in agreement between the Ventana dual-ish and FISH. The main reasons for discordance included borderline cases where the ratio was near the 2.0 cutoff, heterogeneity within the tumor, and how clusters of signals were counted, and possibly reader error. Overall, the consensus panel review favored the Ventana dual-ish score for the 24 out of the 44 cases. There are many articles covering FISH comparison with dual-ish assay, 23 references which show overall concordance averages in the 90% range. Authors conclude that bright field-ish assay is easy to use and less expensive than FISH. Stained slides do not degrade over time and can be stored at room temperature. And the bright field-ish is a viable alternative to FISH. The Ventana HER2 dual-ish assay can be run on benchmark instruments where staining procedures are optimized, ensuring reproducible results with flexibility to address variants in pre-analytical conditions. Hybridization time is faster, and the lab will not need to send out for FISH and wait for results, thus providing a faster turnaround time. Interlab reproducibility has also been assessed with 28 breast cancer cases and 28 gastric cases stained in 3 different labs with overall percent agreement of almost 100%. Within reader and between reader precision was also assessed with agreement percentages between 92 to 97%. Now, how do we interpret HER2 dual-ish assay? Evaluating a HER2 dish slide in a conventional microscope may be summarized in 4 basic steps. First step is to check internal control cells for appropriate black and red signals. Second step is to locate the invasive carcinoma cells with innumerable tumor cells. Third is to count the HER2 and chromosome 17 signals in at least 20 nuclei. And the final step is to calculate HER2 and chromosome 17 ratio, as well as the average copy signals of HER2 in the number of nuclei scored. If the ratio is close to 2.0 cutoff, or between 1.8 to 2.2, for example, an additional 20 cells should be scored. The interpretation guide is included in the assay kit for the pathologist's guidance. What comprises a normal internal control? These could be any non-tumor cell, like the fibroblasts, lymphocytes, endothelial cells, normal breast epithelium, and myoepithelial cells, and should contain 1 to 2 signals each per cell, depending on the plane of section. In the upper image, the fibroblasts display appropriate black and red signals per cell, whereas the image below shows absence of signals in the internal control. If the internal control cells do not stain appropriately throughout the entire tumor specimen, repeat staining is recommended, or another tumor section may be selected. Once the internal control is assessed to be valid, the reader then identifies the invasive carcinoma. DCIS, labeled as A, for example, usually shows HER2 amplification and should not be scored. The area in B, with the invasive tumor, can be assessed on the dual-ish stained slide, and this is where the reader finds appropriate cells for scoring. In selecting invasive tumor nuclei to be scored, the reader should select the area with the highest average number of copy signals within nuclei that represent the average population of tumor nuclei. If the copy signals appear homogeneous, 20 nuclei to be scored may be sufficient. But if copy signals appear heterogeneous, where amplified cells are noted among non-amplified cells, whether in clusters or in a mosaic pattern, it is recommended that the reader scores up to 60 nuclei, and the ISH report includes the proportion of amplified cells within the tumor. Which cells should not be scored? Do not score cells that are much larger or much smaller in diameter than the average size of carcinoma nuclei, or nuclei with weak signals, or areas with compressed or overlapped nuclei or necrotic areas, or nuclei with excessive background that interferes with the ability to enumerate specific signals. In the image on the right, we see high background of silverish dust interfering with the black signals. In these areas, these would not be scored. In the image on the far right, some non-specific red signals are seen outside the nuclei. And again, these areas should not be scored. Using these illustrations, the first cell is scored as having 1 black and 1 red signal, then 2 black and 2 red signals. If black or red signals are close to each other, like a doublet in this illustration, the 2 adjacent signals of the same color is scored as 1 signal. Count 2 adjacent signals of the same color only if the distance between the signals is equal or greater than the diameter of a single cell, or a single signal. So in this illustration, this black doublet is counted as 1, and the red signals here in this illustration is counted as 2. Now, which cells are not to be counted? do not score overlapping nuclei, areas with no signals, of course, or if only one color is present, or if the signals are outside the nuclei. How do we count clusters? Small-ish clusters are estimated by using the size of a single signal as a reference, such as those in stromal cells. This cluster could be estimated as 6 HER2 signals plus 2 black signals to total HER2 count of 8 and 2 red signals in this one cell. In this illustration with the large cluster, the cluster may be estimated as 12 black signals based on the diameter of the black signals to a count of 16 HER2 copies in the cell and 2 red signals. In the illustration on the right, the cluster of black signals obscure the red signals. This can occur in some cases and may be challenging to score. Higher magnification of 60x may be used to confirm presence or absence of red signals when obscured by the black clusters. Otherwise, select cells with clear red signals. Finally, after assessing the tumor adequacy and the internal control and identifying the target area for each scoring and counting the HER2 and chromosome 17 signals in at least 20 nuclei, the reader calculates the HER2 chromosome 17 ratio by dividing the total number of HER2 signals by the total number of chromosome 17 signals. If the ratio is close to 2.0 or between 1.8 to 2.2, the reader should count an additional 20 nuclei. Results are reported as non-amplified if HER2 chromosome 17 ratio is less than 2.0, or amplified if more than or equal to 2.0. If more than 20 nuclei are scored, the HER2 chromosome 17 ratio is calculated from the total tumor nuclei scored. A scoring sheet can be found at Roche Diagnostics eLabDoc, which is a technical document resource online, or your lab can create one using Excel sheets or G sheets. The score sheet would include all the scores for the 20 or 40 or 60 nuclei scored, along with the mean HER2 copy number, the mean chromosome 17 copy number, ratio of HER2 chromosome 17, the ratio of HER2 with the chromosome 17, the status of the internal control, whether there are clusters, or whether or not there is presence or absence of heterogeneity. As per ASCO-CAP guidelines, there are 5-ish groupings. If the ratio of HER2 to chromosome 17 is more than or equal to 2, and the average HER2 copy number per cell is more than or equal to 4.0, this is group 1 HER2 positive. If the HER2 chromosome 17 ratio is less than 2.0 and average HER2 copy number is less than 4.0, this is group 5 HER2 negative. Groups 2, 3, and 4 are considered equivocal-ish categories, varying in their average HER2 copy numbers. The additional workup could mean assessing HER2 IHC from same tumor sections as those used in ISH, or if the HER2 status is not clarified by IHC, a blinded reassessment of ISH by another pathologist should be performed. Groups 2, 3, and 4 are uncommon, as you can see from the percentages per group. For group 2, no clinical benefit was seen in studies. For group 3, the HER2 amplification is masked by co-amplification by chromosome 17. Group 4 comprises the true borderline cases, although this group shows limited data on clinical benefit. If IHC 2+ and a second pathologist scores are the same as those of the first pathologist, the HER2 result may be finalized with a comment at the bottom of the negative results of either groups 2 or group 4. Now, I just want to mention a bit about HER2 dual-ish image analysis algorithm as we use it in digital pathology. There is an element of subjectivity when assessing HER2-ish assays. Thus, there is value in using digital pathology image analysis algorithms, which provide a more objective, automated scoring of HER2 and chromosome 17 signals on a digital image of a HER2 dish slide. Going digital means using high-resolution digital pathology scanners, a pathologist interface on the computer screen to manage and view the patient images and information, and image analysis algorithms to aid in scoring biomarkers more efficiently and more confidently. With digital pathology, synchronous viewing of H&E, IHC, and ISH slides are enabled on a computer screen, syncing the exact tumor areas being evaluated. The scoring of 20 or 40 or 60 nuclei for HER2 chromosome 17 signals are automatically calculated using HER2 dish image analysis algorithm to assist the pathologist. Similar to the HER2 dish workflow, as shown on the workflow flowchart on the right, the HER2 dish algorithm adds visual tools like the heat map. And the heat map shows dark red for areas of high HER2 amplification and yellow for areas of non-amplification. 20 nuclei are automatically selected by the HER2 dish image analysis algorithm, and the pathologist validates whether or not the selected cells are appropriate and representative of the overall HER2 status seen on the slide. The scores for the 20 nuclei are automatically provided in 3 seconds. The ratio of HER2 and chromosome 17 is also automatically calculated, and the pathologist validates the other HER2 information, the presence of heterogeneity, the presence of clusters, and whether or not the internal controls were valid. The use of HER2 dish image analysis is way faster than manual HER2 dish scoring under a conventional microscope, with a 96% overall concordance between digital and manual scores. Of course, even without digital pathology, a lab can still use HER2 dual-ish assay more efficiently than FISH, even as it is being scored in a conventional microscope and not a fluorescence microscope in a dark room. Before I end, I want to remind that there are online self-study programs for pathologists to self-train various Roche Ventana assays. Go to education.ventana.com. This e-learning portal includes HER2 dual-ish interpretation. And it is a free education portal, and there are didactics as well as guided slide review and, and, and a proficiency test. In summary, Ventana HER2 dual-ish assay is a CVE-IVD marked assay indicated as an aid in the assessment of patients for whom HER2 targeted therapy is being considered for either breast or gastric cancer. This bright field assay allows for interpretation within the context of tissue morphology. The assay has been optimized with high concordance with FISH. With full automation processing, we ensure reproducible results and a faster turnaround time to complete a widely adopted breast cancer and gastric cancer portfolio. For further guidance, it is highly recommended to use updated ASCO-CAP guidelines for HER2 evaluation as reference. Thank you very much for your kind attention.